Welcome to another episode of Dear Parents. Last week we had an interview. This week I have a couple of different articles that I want to talk through that are relevant to essentially all parents. I try and make a smattering of things that will be relevant to everybody. The one that will definitely be relevant to everyone today is about screen time. This is a specific article that I saw that really caught my attention, and it's been going around a little bit on social media. Although I do, to be honest, feel like social media, and especially with the Meta stuff this week coming out, they definitely try and put a little throttle cap on how much anti-social media stuff actually makes it on and circulates around social media. I have found with my own stories and articles and reels and things like that, if I'm talking about how bad social media is for your kids, there's a cap on that compared to other non-things about social media and screen time and everything like that, which I guess, I mean, Meta is what it is. It's a bad organization that knows exactly what it's been doing to kids, but as one would expect, they try and make themselves look good by throttling that sort of content that gets out there. That was an aside that I wasn't planning on going into, so sorry for my little rant there. But that is the first article. And then we have one about Nirsevimab, which is an RSV antibody. And there was an article that looked at avoiding antibiotic exposure by avoiding RSV. And so that was a cool article. And then the last is a parent question about croup. And croup is especially relevant to those with children under the age of 5 going into respiratory season. Now, if you have a question, I would love to answer your questions. Swipe over to your show notes and then click Ask Dr. B, and you can get your question asked and answered on an upcoming episode. Hopefully this episode has lots of good nuggets that help you to enjoy parenting more. Okay, there was an article that caught my attention this past week. It was in JAMA Pediatrics, the Journal of the American Medical Association Pediatrics, and it was titled Screen Use and Children's Language Development from Ages 5 to 7 years old. What this study was looking at children's screen use and their language development. And so their receptive grammar, their receptive vocabulary, their expressive, and so on. And they were looking at language and the specifics of how they specifically monitored and measured that are less relevant to us because we're not speech pathologists. But they looked at language development in children that had devices and those that did not have devices. And then what the number of hours of devices exposure did to their language development. I doubt that it will be surprising to many of us that more device time impaired language development. And that is what the study found. One of the things they looked at, and I'll just tell you the points, although they're not super relevant to you without knowing kind of the scoring system, but children who owned a digital device at ages 4 to 5 years scored lower at baseline, both in receptive grammar, 5 points lower, and 5 points lower in receptive vocabulary, compared with children who did not own a device. And so when I think about that, I know that most kids do own a device these days, and I think that ownership can be a spectrum. They can have unlimited access to their tablet and they can get it whenever they want, or it can be something where, yes, this is your tablet. It's got your little safety wrapper thing around it. The rainbow one is Helen's, the purple one is Gloria's, and so on. You own this device, but you don't have unlimited access to it. We as parents put guidelines and expectations in place so that, yes, this is technically yours, but that doesn't mean you get carte blanche access to it. The more hours that the child had on their device, the more of an issue it was with language development. Unsurprising to all of us. Now, the thing that really stood out to me in this article, though, this already supported what I thought, was that more time on screens impairs language development. The real thing that stood out to me is that primary parent smartphone screen time was associated with slower growth in receptive vocabulary. Each additional hour per day was associated with slower annual growth in receptive vocabulary raw scores. And so what that means is that there's a dose-response relationship here. The more time that the parent spent on their device, the slower the child's language development. And I don't share this with you to make you feel guilty because we are all on our screens for a variety of different reasons throughout the day. And I'm going to tell you where I would start if you say, okay, this makes me think I should probably get a handle on this. I've been meaning to get a handle on this and I just haven't. I'm going to share with you exactly where I would start in just a moment here. But what we know and what studies have shown over time is that more parent smartphone use results in fewer child-parent interactions, less attunement, and less words spoken to the child. If we're frequently on our phone, our child might see that and they might say, well, they usually don't respond to me. They're like, what? When I try and get their attention, so I'm not even going to do that. Or when there's a moment where we could say, wow, look what you're doing there, but you're distracted by your phone, your child is doing something, and you just don't say anything because you're distracted by your phone. This happens to all of us. It's not the end of the world, but it is something that we can get a better handle on. And so if I could help you, what I would do is I would say, go turn your screen time settings on if they're not. I always get, it's funny. We go to church typically on Sunday mornings, and whenever we're at church, it seems like that is the time that Apple sends me my screen time message for the week. I don't know if it was designed that way as like an added guilt trip or something along those lines, but it always pings me during church that here's your screen time for the past week. So make sure you have your screen time settings on. I don't think you can pick when Apple is going to alert you. They maybe have some sort of location tracker of like, I'll let them know while they're at church. But what you want to do is turn that on. And then instead of, I mean, it's good to look at your overall hours, but what I want you to focus on right now is not your hours, but your pickups. And so if you scroll down under there, you can see, and I always set it to weekly average rather than day by day because it varies day by day. Sometimes we're on our phone more, sometimes we're on our less, but a week by week average gives you a good sense. And so daily pickups, and it probably won't go into focus here. I'll share with my screenshots, but you can see the number of pickups and what you do first. The more times you pick up the phone, the more times you are distracted by your phone. And the more times you pick up the phone, the more that it is interfering with being present for the people that are in your lives. And so if I was going to pick a target to work towards, this is an easy one to pick to work towards because you can see, so this week so far, my average has been 57. The week is still young. Last week, it was 88 pickups per day. The week before that, it was 85. The week before that, it was 88. So I'm around 80 pickups per day. And just going in and looking at that, you will see an improvement in how many times you pick up your phone, just from the simple fact of noting that number. Now, you could also scroll down one more and look at notifications, because notifications and pickups are highly tied together. If I get notified more frequently, I'm going to pick up my phone on a more regular basis. If I hear that ding from across the room, or if I hear it on my watch, I'm much more likely to go find out what's going on. And even if I don't at that moment, say I'm really trying to be present at mealtimes and we don't have our screens at mealtimes, but I hear that ding from across that room, or I feel that notification on my watch, I'm instantly pulled out from the moment of being with my family and thinking, I wonder what was just said. I wonder if this is important. I wonder if this is something that I need to look at right now. I wonder if it's that email that I was waiting to come back in, or I was wondering if that text from that person that was waiting to respond. Those distract you too. So I would say turn off all of your notifications and see how much stuff you don't actually miss over the course of the week, because it's very unlikely that your notifications are giving you any information that you must act on in that very moment. And we are really intentional about essentially no notifications other than text messages from immediate and extended family getting through to us on a regular basis, and we don't miss anything. And so I would do that, but then I would also see where you're at with your pickups, because your pickups are going to give you the best indicator of how many times throughout the day am I distracted by my phone? How many times per day am I being pulled from the moment into my phone? And I'm going to do one better for you, because I would love to just help you to get a better handle on this. There's nothing to sign up for or anything along those lines. If you would, go click on the show notes, and there's a comments, and that will take you to the post for this podcast episode. And what you can do there is share a screenshot of where you're at right now for pickups. There's no judgment if it's 20. There's no judgment if it's 400 pickups per day. Anywhere in there is fine, because that's where you're at right now. And you're saying, hey, I want to be intentional about this, and I want to decrease this by 10% or 20%. The act of noting it, the act of having the accountability of commenting, will help you to get to a better place. And I will keep talking on my Substack about ways that you can have fewer moments of picking up your phone. The best one to do is first make it easy to not pick up your phone by turning off notifications. And the second is to keep your phone off your person. I am guilty of this too, is sometimes I will carry it around in my pocket. Then it makes it really easy to pick it up and see what's going on. Even if I'm walking up the stairs or going to grab a soda or something from the garage fridge or something along those lines, it's really easy just to pull it out. If this is not on your person, it's really hard. You have to be much more intentional to veer over to the kitchen or the island or wherever you keep your phone when you're not actually engaged with it. Those are the two ways that I think make the biggest difference when it comes to intentionally reducing our screen exposure, is to just put it out of reach and not constantly get pinged by the little notifications that can go off all day long. So my challenge to you is to go comment on this post with where you're at right now this week for your pickups, and make the intention of I'm going to try and get 10% less pickups. So I'm at 88. I'm just going to try and pick up my phone 8 times less per day, which feels like that is doable because there's certainly times where I can just not pick it up. I can go do something without picking up my phone. That will help to decrease this number. And we have plenty of studies that show this one that I picked on here specifically will help to be more present as a parent and to support your child's language and emotional development from that simple choice. So after the music, we're going to keep talking, but I just wanted to share that with you as today's article. All right, now in this section, I want to talk specifically about the coming respiratory viral season and something that caught my attention. It was an article that just came out. I'm going to put it up here on my screen, which is certainly too blurry to actually see on YouTube or on Substack if you're watching. But it is called The Effectiveness of Nirsevimab on Antibiotic Use in Children. This was a study that looked at RSV and antibiotic use. And so if we think about RSV is a very common winter ailment for children, especially in the first few years of life. And one of the things that goes along with RSV is increased work of breathing, increased cough, difficulty breathing. And if we look at Children's Hospital and pediatric wards, it is the number one cause by far and away of hospital admission for children in the first year of life. I remember several years in a row when we had some bad RSV stretches where I would be calling around the region to try and find a hospital bed for a child that's in my office that is having difficulty breathing because the hospital wards were all full of RSV. I was sitting in the children's floor at our local hospital calling and saying, can you take this child? Like they're having increased oxygen demands, they're having increased needs, they might need the ICU, they might need mechanical ventilation, all those sorts of things. And several of the surrounding pediatric ICUs were closed because they were just so full. So there is a huge burden of RSV in the winter months on our community. Now, in the past 5 years, we've had something new that has come on the scene that has actually had a dramatic impact on RSV hospitalizations, and that is a medicine called Nirsevimab. Now, parents often hear about it and think it's a RSV vaccine. It is not an RSV vaccine. When we think in general about vaccines are given to a child or an adult, stimulates the immune system to react to whatever the vaccine is for, whether it's measles, whether it's pneumococcus, whether it's chickenpox, what have you. The body is making the immune cells, like the T cells and the B cells, and the antibodies. Nirsevimab is actually a monoclonal antibody. And if you've ever watched TV for one commercial break, you are very familiar with monoclonal antibodies because they are very popular in life-changing in the adult space for a lot of autoimmune conditions, a lot of different like GI autoimmune stuff, skin autoimmune stuff, joint autoimmune stuff. Monoclonal antibodies are specific antibodies that target something specific in the body and can help to reduce those symptoms. Nirsevimab is actually a monoclonal antibody against RSV. So we give this to children, especially in the first year and only in the first year of life, typically for RSV prevention. It is not a vaccine, it's actually the antibodies themselves. So we're giving them the antibodies. The antibodies then are surveilling, they're watching for RSV. So a child goes home from the hospital, they're born, they go home from the hospital, and their sibling wants to see them, has a snotty nose, is in daycare, school, or around other kids. At some point, they might have RSV, but this infant is protected because they've got those antibodies that are circulating. So when the sibling sneezes on them, or at church, somebody gets too close, or at Target, everybody's wanting to touch, or those sorts of things, and the RSV is seen by that infant, those antibodies are there, they're circulating around, they say, hey, this is RSV, let's knock it out before it starts to have symptoms. And we've seen a dramatic decrease in hospitalizations. Like it is 80 to 90% effective at preventing hospitalization, which when I was telling you the hospital wards are often full of children, that is a dramatic decrease in the number of children that are having to be hospitalized for RSV. Hospitalization isn't the only negative outcome associated with RSV. There are children that pass away each year from RSV because of the respiratory issues. And so they can have severe cases of RSV where they're on the ventilator, they're even on ECMO where they have to do artificial breathing and artificial cardiac support for these children. But assuming that that's not the issue and we're talking about something less grave than hospitalization, ICU, those sorts of things, RSV does increase the likelihood of asthma. If a child gets RSV in the first year or two of life, their likelihood of asthma or other chronic respiratory issues can be higher. And this article looked at specifically antibiotic exposure and RSV. Now, when you think about RSV, the V stands for virus. So we shouldn't be giving these kids antibiotics to begin with. But children that have RSV are at a higher risk of being exposed to antibiotics. And we want to do whatever we can to avoid antibiotic exposure. And so this study really looked at, does Nirsevimab, does giving that monoclonal antibody to protect against RSV have the side effect of preventing antibiotic exposure? Antibiotics are great. They are life-changing, and we should use them appropriately when they're appropriate. But when we can avoid using them, we should at the individual level to prevent all the side effects to mess up the gut microbiome. And then at the societal level to avoid antibiotic overuse, things like decreased antibiotic effectiveness, multi-drug resistant organisms, all of those sorts of things. There's plenty of good reasons that we should be avoiding antibiotics. What this study showed is that giving Nirsevimab to prevent RSV actually leads to decreased exposure to antibiotics in the first year of life. When a child gets RSV, oftentimes they'll go into their doctor. Sometimes they'll have to go into the urgent care or to the ER, something along those lines. It can be difficult to know, is this RSV? Is this a bacterial pneumonia? Let's cover our bases. And so if they go to somebody that practices in that sort of way, then they're getting exposed to antibiotics because they have a viral illness. And a lot of times, especially if it's more care that is not delivered in a medical home and they go to urgent care or something like that, they're going to cover their bases more. I don't want you to have to come back. I don't want you to have something bad happen. I don't know you. I don't know if you're ever going to come back. So I'm just going to play it on the safe side, giving an antibiotic just to cover just in case. Well, you have a viral infection. It's not going to do anything except all of the side effects that can come from antibiotics. But if we can avoid RSV, we can actually reduce the likelihood of getting an antibiotic. On the other side of the coin, children that get RSV or other respiratory ailments often get an ear infection after that. And that would be a time where we might want to use an antibiotic. We try and avoid antibiotics when possible for ear infections because most ear infections will resolve on their own. But if they're sick, if they're having fevers, if we're trying to eliminate the other things, then we may be more likely to reach for an antibiotic when they have an ear infection with RSV. If we can prevent RSV, the study showed that you actually reduce the likelihood of an ear infection, reduce the likelihood of antibiotic exposure. So just a couple of the numbers specifically, 1 out of 3 hospitalizations for acute respiratory tract infections in children less than 5 is RSV. And almost exclusively in children under 12 months of age, hospitalization is because of RSV. There are 57,000 hospitalizations in the United States for RSV every year, which is a lot, and 1.5 million visits to the pediatrician's office. So imagine taking that 57,000 hospitalizations and then overlaying that with getting these children Nirsevimab and seeing a 80 to 90% reduction in the risk of hospitalization, 80, 90% reduction in the risk of getting RSV and needing to go into your pediatrician's office. Approximately half of children hospitalized with RSV and up to 30% of children who present to an outpatient clinic will receive antibiotics. Some of them appropriately, some of them inappropriately given antibiotics. We know, and the thought was, okay, when we've done other vaccinations, we've seen a decrease in antibiotic exposure. Things like influenza. If you get a flu shot, you have a less likelihood of getting an antibiotic the coming year because you're less likely to get the flu, you're less likely to get pneumonia, you're less likely to get ear infections and the things that can come after the flu. Same with Haemophilus type B, which is known as Hib, strep pneumo. When we get those vaccines, it reduces the likelihood of antibiotic exposure. So actually, if you're worried about antibiotic exposure, vaccinations are a great way to prevent antibiotic use. And what they looked at over 15,000 patients who met the criteria, and giving Nirsevimab reduced the likelihood of antibiotic prescriptions in the outpatient setting by over 15% for outpatient respiratory tract infections. And specifically for those with RSV, it reduced it by 40%. And then over 70% for those needing hospitalization. So we know just all comers, 15% reduction in the likelihood of getting an antibiotic when you have a respiratory tract infection. If you specifically have RSV or bronchiolitis, it was a 40% reduction. And if you were hospitalized for our percent reduction in antibiotics prescribing. So we're dramatically reducing the RSV-related hospitalizations in general. And then on top of that, we're avoiding antibiotics when they do need to get hospitalized too. They talk in this study about the reasons that you get antibiotics. RSV can mimic other bacterial infections, or it can predispose them to ear infections or things along those lines. And so this is a study to me that supports, again, the use of Nirsevimab. And what we do in our clinic is we offer it starting in October to any babies going through their first RSV season. It is a shot. It is a tiny amount of liquid that we give as a shot. It has usually fewer side effects than even a vaccine because it doesn't stimulate the immune system in the same way. So yes, babies don't like getting a poke, but a minute later, they're already back to normal or they're feeding or something along those lines. We typically see a little bit of injection site redness, not typically fever or other symptoms ongoing or fussiness or things along those lines because it's not stimulating the immune system in the same way that you would expect a regular vaccine to do so. This is just the monoclonal antibodies. They circulate around. The cool things about it is that it lasts for 6 months and it starts working within hours. So this can be given actually in the hospital before you go home with baby, or the first days in clinic or the first weeks whenever parents are able to get in and get it done. It starts working almost instantaneously, which is great when you're going home to a family of snotty-nosed toddlers and bigger kids. So hopefully this makes sense. If you ever come across a study that you're curious about, or if you see something, please send it my way. I'll put in the description, the show notes, exactly how to ask a question. But I love getting to work through these sorts of things. And hopefully this has given you something to walk away with from, if we can prevent respiratory infections, then we can prevent antibiotic exposure and how those two are specifically linked. If you know of somebody that's having a baby, if you know of somebody that just had a baby or is entering their first RSV season, make sure and share this episode with them so that they can get that good information and then make an informed decision with their pediatrician, with their healthcare team around the use of Nirsevimab to protect against RSV this coming winter. All right, so in today's listener question segment, which, by the way, click in the show notes if you have a question. I'd love to get to answer parents' questions. It's much better for me than just talking and rambling and having the things that I want to say. I'd rather answer your questions. This is a question specifically about croup, and it is timely and relevant as we enter fall respiratory season.
Hi, what are some things that you can do at home when your child has mild to almost severe croup? Didn't know if a prescription from nebulizer is required or if I can just buy all those things to have at home when it starts to come on. Thanks.
So this is a great question and comes up all the time, is like, how do we handle croup? Now, as a little bit of background, if you're not familiar with what croup is essentially a narrowing of the upper airway that can cause the typical symptom of a barky cough and sometimes difficulty breathing. Croup is typically caused by a variety of wintertime viruses, everything from flu to paraflu to the whole host of other viruses will cause croup symptoms. What croup is it actually a narrowing of the upper airway because of inflammation. And so if you think about you as an adult getting laryngitis, your airway gets inflamed, you get that crackly voice, maybe some more difficulty breathing if you're trying to breathe in deeply. That is what happens to your infant, but their airway is really small. And so what happens then is they get that barky cough because of a very narrowed airway. Sometimes it will get so narrowed that even at rest, you can hear them breathing, and we call that stridor. It's that inspiratory noise of, and that's what it sounds like. Sometimes they'll do it at rest, sometimes they'll do it when they're upset or when they're feeding or something along those lines, and that's just air entering through a narrowed path. If you think about what the analogy that I often use is if you've got your garden hose and then you kink it, you start to hear a little bit of water rushing through there. And then if it's almost completely kinked, like no water's coming out of the hose, you hear the water rushing through there louder because it's a more narrowed aperture that the air is passing through. And that's what makes that kind of scary noise. They will get a barky cough like a seal as well, like and that's just forcing that air out through that narrowed passageway, leads to that more barky sounding cough. When parents tell me barky cough, it's usually croup. What to do at home. So your child, they get home from daycare, you're settling in for the evening and they start getting that squeaky noise and they might have a fever, they might have a runny nose. You're like, great, here we go. First, don't panic. Most children with croup, the vast majority of children with croup, can be handled tomorrow in the office, and you don't have to run to urgent care or the ER typically for croup symptoms. What you're going to do, let me just start with what would send you to the ER to get evaluated that same evening. That would be difficulty with breathing, like they're really tugging in with their breathing, even at rest, even when you've controlled for their fever. And the reason that I say controlled for their fever is if you have a child that has a fever, they're going to be working harder to breathe and they're going to be breathing faster. And so I don't think it's a fair assessment if they're 102 and they're working hard to breathe. What you need to do is reduce their fever with Tylenol or ideally ibuprofen. If they're 6 months of age or older, ibuprofen just works better. Reduce their fever, and then you can look at their breathing when they're fever free. That will reduce their respiratory effort. That will reduce their metabolic demands. And then you can get a better sense before you run to the ER of looking at those things. But if they have difficulty with breathing at rest, ER, are really loud even when they're at rest, then that's something where you're going to talk to your pediatrician and they might send you into the ER. Typically, though, they will have more barky cough. Sometimes they'll have a little bit of stridor, that inspiratory effort, if they're upset or feeding or something along those lines, but then it calms down and they're mostly breathing quietly thereafter. Those are times where then we usually say, okay, let's see you the next morning. What are you going to do that night at home, though? Because you're not just going to sit on your hands when your baby is barking and making all these noises. The biggest thing is normal respiratory cares for any respiratory illness. The most important thing to have on hand is some nasal saline. Nasal saline costs like $2 for a big adult size nasal saline bottle. You don't have to get like a special kids one. It's just nasal saline, and you really aggressively spray it in there and you suck out what you're able to. That helps to make it easier to breathe because it reduces the snot that's interfering with easy breathing and easy eating. And so doing that on a regular basis helps to get that out. Ibuprofen, if they're 6 months of age or older, is an anti-inflammatory. And so what that can do is help reduce a little bit the inflammation that's going on in the airway. It helps with pain. It helps with the discomfort, with the fever, all of those sorts of things. And so ibuprofen once they're 6 months of age. If they're under 6 months of age, then acetaminophen is a good option for pain reduction and discomfort reduction as well. Obviously, if they're under 3 months of age or if they have a fever or something like that, you're going to be talking to your doctor's office. So don't take this as medical advice in any sense of the word. These are just the general guidelines that you could look up or ask your favorite AI agent about when it comes to croup. So nasal saline, reducing discomfort, reducing inflammation as you're able to. One really specific thing for croup is cool air. Now, if you think about the inflammation that you get when you sprain your knee or sprain your ankle or something like that, there's swelling. Inflammation causes swelling. And if we can reduce the swelling, then we're going to breathe more easily. And so what parents do when we're saying like get them some cool air is if it's the winter, which is when croup is common, you take them out in the cool night air and you let them breathe that in for a few minutes. That can help to reduce the airway swelling, much like putting an ice pack on your ankle. Breathing in that cool air can help to reduce that swelling. Now, it's not the miracle cure, but it does help, especially if they're a little bit barkier or having trouble getting comfortable. So you bundle them up, but you let them go breathe in some cool night's air. And then on what seems like the flip side of that is a steamy shower. So steamy shower helps to get more humidity into the airway. It helps break up all the gunk that's up there, causing all of that. So taking your baby in a steaming shower can also help. I don't know if there's a best cool night air to steamy shower. I'm not sure if there's one to do first or the other. You're up with your baby. You can try and see what works best. I don't have a protocol or something like that for those. Just don't mix them up and take them out in the hot air and then do like a cold plunge or something along those lines. Cool night air, steamy shower can both help to reduce the symptoms of croup so that everybody can get some rest. If your child is 12 months of age or up, you can also use honey. Honey helps. It has actually, just outside of just soothing the throat and tasting good, honey actually has some anti-tussive, anti-coughing properties to it. Now, you don't have to go get the fancy ones from the pharmacy that are all branded and full of other sorts of things. The honey that you use on your biscuits, the ones, sometimes they're like even in the little bear shape, works perfectly fine. And that's what I tell parents to get. You don't have to go get something special. The regular old honey that you use for your tea or for your biscuits or whatever it might be works perfectly fine. It's much cheaper. And so I always tell parents just to use that. The one caveat of that, like, well, first of all, make sure they're 12 months of age, because under 12 months of age, there is a risk of botulinum toxin botulinum bacteria causing problems. So under 12 months of age, we're not going to use that because of that risk. But once they're 12 months of age, you can do that. The only problem is they'll get into the habit of, I've got a little cough, I need some honey. And so you sometimes have to work that through that on the other side of like this habit of, can I have some honey sort of thing. Now, you're going to go into the office the next day and you're going to tell your pediatrician, hey, they're a barking cough, they're having some trouble breathing, they've got these runny nose and respiratory symptoms. The vast, vast, vast majority of those children should just get a one-time dose of steroid. Steroid helps to more dramatically than the breathing in the cool air. Steroid helps more dramatically than the ibuprofen anti-inflammatory to reduce that airway inflammation. And so the one that we use is called dexamethasone. It is cheap. It is something that we have in the office that we give rather than send them to the pharmacy to then wait and get a prescription or those sorts of things. It usually works within hours. So if I see them before supper time, there is relief to be sought by bedtime. And so when you get in and you get that dose of dexamethasone, you can expect that their croup is going to get better that same day. It usually starts within 6 hours and it lasts for at least 36 hours to help reduce that inflammation and get through that. Very rarely do they need a second course, like a day or two later, but that is something to keep in mind. Now, one cool trick with the dexamethasone is in the past, it was given as a shot, which is not very kind to do to children. And it will cause more croup symptoms. Like when they get upset, they bark more and they have more stridor. And giving a kid a shot of a nice little amount of liquid will make them uncomfortable and it will make their croup symptoms worse. What we do and what you can do and what a lot of ERs and urgent cares are starting to get on board with now is you pull up the medicine just like you would as if you were going to give a shot. And then you take the little needle off and you give the medicine orally. It doesn't taste great, but it's a tiny it's the volume that you'd give in a shot. So it's less than 1 milliliter total, but you can give it orally and it works just as well and it works just as fast and it doesn't cause vomiting. So if you go into your doctor's office and they're pulling up the syringe full of dexamethasone to give your child for croup, you can say, hey, do you mind just giving that orally? And if they're like, what the heck are you talking about? Have them do a quick Google or chat session to find out that that is a very acceptable thing. I can't think of in the past 12 years as a pediatrician where I gave a shot of dexamethasone for croup because every child tolerates it well orally and it doesn't cause them to throw up. That's something that I've heard other people say is like, well, we just do it as a shot so they can't throw it up. There's actually been studies that have looked at there's no higher rate of vomiting with giving it orally than giving it as an injection. It works just as fast. So in my opinion, there's no good reason to be giving shots for croup when we can give a medicine much more nicely orally without even having to order a different medicine. It is the exact same medicine that you give intramuscularly. You just take the needle off and you give it to them by mouth. Now, one of the things that doesn't help, which is what this mom asked for in this message, is nebulizers. Nebulizers don't typically help for croup. When I think about outpatient, like at-home nebulizers, that is typically albuterol, which helps with the lower respiratory tract. We're talking about asthma and things along those lines can be helped with a nebulizer. Because croup is an upper respiratory infection, meaning before you get to the lungs part, albuterol actually doesn't typically help with croup symptoms. There are some treatments. If you go into the ER, they might give you racemic epinephrine, which is a aerosolized version of epinephrine to really open up the airway because they're worried about your impending airway closure. And so they will give that. That is not something that we do in the home setting. We have it in our office. Can't say that I've maybe once in 12 years ever had to use that on a severe case of croup in the office setting. And so it's definitely not something that you would have on the home front that you would use on a regular basis. There are some people that have started using more like nebulized saline to help. So that might be something to talk about, but it really isn't the standard of care when it comes to croup. It's not necessary. It's a bunch of equipment. You have to try and get the kid to keep it on their mouth and those sorts of things. So in general, that is not a tree that I bark up when it comes to the management of croup at home. Some kids will recurrently get croup. These kids we typically know about and parents know what to do. If they are the type that really goes quickly from just a little bit of bark to, okay, do they need to go to urgent care? Do they need to go to the ER? We will often give them the dexamethasone to have at home. We have a small practice, so we feel comfortable. We know our patients. We teach them how to draw up the medicine, when to use it, what to do after you've used it, all those sorts of things. But that's definitely something to talk about. In terms of preventing croup, there really isn't anything that you can do to prevent croup other than avoid respiratory illnesses. Avoiding respiratory illnesses looks like all the normal wintertime ailments. I talked earlier in this episode about preventing RSV with Nirsevimab. Getting your influenza vaccine is a great way to prevent influenza causing croup, but a lot of those respiratory pathogens are just out there in the community, and there really isn't anything that we can do other than hand washing, other than trying to avoid them with all the typical measures we do. So hopefully this has been helpful. Hopefully that was probably more of a deep dive of croup than you may have wanted, but those are the main things that I tell parents when it comes to croup. If you have questions, show notes, Ask Dr. B, click that, leave your question. I will answer it on an upcoming episode. Keep up the good work.